Well, thank you very much. This is a great case, and I just need to warn you, Alberto, that following Roderick's presentation, if you think that I'm going to disagree with Roderick, then I'm sorry to disappoint you. Let me dissect the case. This is my conflict of interest disclosure, and I'm going to take you back to the patient. When we are faced with a patient like the one that Isabel has told us about, what does the patient actually want to know? Well, he wants to know how serious his cancer is. And on the right-hand side here, I've put tick boxes which have three colors, red, green, and amber. Wherever the tick is amber, it means we have substantial uncertainties. When it is green, we have a lot of answers, and when it's red, we have total uncertainty. So the first question is, how serious is his cancer? Well, we have some uncertainties about it, but we don't have the full information. How accurate is the information to date? Well, all the things that Isabel has done have been up to date with the current investigations that we have. Will the cancer kill him? Many uncertainties. What is the best treatment for him? Definitely not enough information. What are the treatment side effects? Yes, we have a lot of information. Will the cancer come back and spread? Uncertainties. What happens if we did nothing? We kind of know what the statistics tell us. So if we go back to the patient characteristics, he's 65-year-old, and as pointed out by Roderick, he's borderline for benefiting not just from treatment, but also from screening. There's no question about that. He has no comorbidities, no regular medication, no abdominal surgery. So he has a good long life expectancy and no contraindications technically for offering him any type of radical treatment. He has an unfavorable feature with a family history of prostate cancer in his second-degree relative, and he's at slightly higher risk of having a significant aggressive disease. When he had his first transrectal ultrasound and biopsies, the diagnostic pathway in 2000 was suboptimal and bears no relationship really with the current diagnostic pathway, which has been alluded to in terms of MPMRI, possible genetic testing, LATP, local anesthetic transperineal biopsies to reach particularly the anterior parts of the gland, and a combination of targeted systematic biopsy. So you did not benefit from all that at the initial presentation. His clinic visit, the elevation of PSA is worthy of further investigation. There's no question about it. PSA velocity, really, we don't use it. I'm not sure how much it is used, but it really hasn't proven the test of time in the long term. 563 prostate health index. If you look at the strict definition, yes, he has a 50% probability of cancer with a 95 confidence interval of 39 to 61%. Prostate volume is small, so he may be in some centers ineligible for brachytherapy, who sometimes have a threshold of 30 cc. IPSS is low, so again, this allows him to receive any potential treatment. MPMRI, PIRATS 2, we heard that. Now we know that even with PIRATS 2 and lower, there is a 5 to 15% risk of missing a significant cancer. And this piece of information actually needs to be given to the patient. This is a good sign. It's reassuring that the PSA elevation is genuine, and there's nothing on digital rectal examination. We know the DRE's sensitivity is very low, but it is actually quite substantial in locally advanced disease, so we know he's unlikely to have locally advanced prostate cancer. I put down here some references to the comments that I'm making. What about the diagnosis? Well, he had a transrectal ultrasound prostate biopsy, 10 core systematic and 5 target. And I think most people would not do a PIRATS 2 target biopsy these days. But this may be superseded by the expanding approach of transperineal biopsies in the future for more accurate definition of the cancer. Histology, Roderick gave a very elegant explanation of cribriform. It is definitely perceived now as a risk factor. with all the reservations that Roderick has mentioned. One question which I had for Isabel is that she's put a percentage, 33%, but no length of course, which some clinicians and pathologists like to see or report. And the MPMRI, has it helped in defining the abnormalities towards the apex? And the reason I say this, we'll come back later, is about the nerve sparing, decision to do nerve sparing or not. Gleason score, you heard enough of that, but he has got high volume disease. It's low intermediate risk. And the assumption is that the patient probably had prostate cancer 20 years before, and he has been receiving active surveillance. The negative biopsies in 2000 do not necessarily exclude cancer. It may have been undiagnosed. So he's been on active surveillance for 20 years, which is fantastic. Then the therapeutic options. So he's being offered radical prostatectomy or radiotherapy or brachytherapy with neoadjuvant androgen deprivation or active surveillance. But what evidence, what can we tell the patient about what we know about this? Well, very kindly, Roderick cited our work, and what you can see here is 10-year median follow-up following diagnosis, 1% mortality irrespective of the treatment allocated, 10% all-cause mortality irrespective of the treatment allocated. But when you come to a local progression and metastatic disease, there's a 50% reduction by active treatment at the time of diagnosis, or within 9 to 12 months from diagnosis, most precisely. What about side effects? You know, the patient wants to know how is he going to cope with the treatments, and how is it going to affect his quality of life? And again, we've got some answers here from the PROTECT study. This is what happens with urinary continence, a very substantial dip immediately after surgery, which returns to some kind of normality, but not quite to the baseline, less so with radiotherapy. And with active surveillance, there is a dip also, which is just related to aging. Erections and erectile function, again, mostly impacted by surgery, less so by radiotherapy. But again, look at the active surveillance cohort here. There is a dip in erectile function with age. And radiotherapy will cause most of the bowel problems. Some of them will last a long time. Now, if anyone says, well, actually, this was open surgery, it was conformal radiotherapy, not IMRT or the more modern techniques, and it wasn't brachytherapy. Well, look at this series from the US, and there are two of them. One is Barocas and one is Chen in the same issue. And you can see that looking at contemporary patient-reported outcomes in terms of continence, erectile function, and bowel are virtually the same as what we found in PROTECT. So all these data are completely valuable. The unfavorable features Roderick mentioned: the family history, the tumor volume, the Gleason 4, and the crib reform pattern. This is probably one of the most recent papers on crib reform patterns, and again, as was discussed, they're more likely, not necessarily, but more likely to develop lethal disease if there are crib reform changes. In terms of treatment, the histology, I haven't heard about surgical margins. I assume, Isabel, that they were clear and well done. If they were, I question the necessity for lymph node dissection. I think a lot of people would not, with a Gleason grade group 2, a PSA of that kind, and with the MPMRI, would not actually go as far as doing a lymph node dissection. And the yield of the lymph nodes for an extended pelvic lymph node dissection seems to be low at 12 nodes only. Well done with the postoperative period. Excellent biochemical outcome very quickly after the surgery. Very good continence and tumescence, even with help. Medication is promising, and if there is a discussion or a minute of debate is about how do you make your decision for bilateral nerve sparing. So would I have offered this man active treatment? Yes, I would have, as one of the options for his management, including all the radical options which are available and active surveillance. How would I counsel him? Well, I would tell him this, and I've really transcribed this from a normal consultation that I would have with the patient in the clinic. I would tell him that a radical treatment is unlikely to make a difference to his mortality at 10 years. We are waiting for our 15-year outcome, and you've heard about the PIVOT study, which shows some differences for the intermediate risk group. And this is what I mentioned here. Radical treatments reduces the risk of disease progression by 50% at 10 years compared to active surveillance. So in other words, with active surveillance, the patient has a 20% risk of the disease progressing, but without impact on mortality. And if he receives treatment, it doesn't go down to 0, it goes down to 9%. Surgery and radiotherapy offer equivalent oncological outcomes, and the side effect profiles of radical treatment are very different. Surgery offers worse urinary sexual function and radiotherapy can have long-lasting bowel side effects. But, and this is something that we keep forgetting telling patients, is as patients get old, they will also suffer functional outcomes which are unfavorable regarding continence and sexual function. So where is the final decision? It's actually about trade-off, trade-off, and trade-off, and it's a decision which needs to be combined between the patient, his partner, and the clinician that looks after them. And for one patient, the side effects are too high compared to oncological benefit, and for another patient, the oncological benefits are sufficiently high to take the brunt of side effects. And this is entirely patient-dependent, should not be doctor-dependent. Thank you.